So I wanted to start by asking you about the tour that you just went on at the end of last year. You had 34 appearances all across the UK, which you did in less than 2 months, meeting, I imagine, thousands of women.
Yeah.
What were you hoping to achieve and how did it go?
Just loved it so much. There's something very special about like an audience, a live audience, being there, responding to their emotions. And then I did a book signing at the end of every show, so I could really feel the energy from the people and really hear firsthand. And that was really quite special, actually. It's all very well having people that follow you on Instagram and send you DMs, but this was quite different, and going all over the country was great as well.
What were some of the highlights or maybe surprising questions or some of the most special moments for you?
I did a live Q&A, so people could write in questions at the beginning of the show and the interval, and then I went through them at speed and picked out like the ones that were most relevant, really. But just reading the questions, we had thousands of questions over the
Wow.
34 days. But it's really sad because actually everywhere, it doesn't matter where it was, people are really struggling to be listened to, really struggling to be understood, being turned away, being gaslit. And that, I feel, I knew it was happening, but when you hear it and see it, and a lot of women, especially struggling to get hold of testosterone, which they really want, or they've been told they're too old, they're too young, they're too fat, they're too thin, they can't have, they shouldn't have, they mustn't have. And I just thought, gosh, if I was doing a tour about diabetes or doing a tour about raised blood pressure, the questions wouldn't be like that. It'd be very different. It was a mix of emotions. I felt joyous and happy, but I also felt really sad and frustrated.
We're going to talk a lot about hormones today because I know that's your wheelhouse, that's your ultimate area of expertise. I'm really excited to learn. And we're going to talk about HRT. But before we do, I just wanted to zoom out a little bit and ask first, what does a healthy hormone life cycle look like?
When we talk about hormones, all they are chemical messengers that everybody has in their body. We've got hundreds of different hormones. They just go to every single cell in our body and help our body, our cells, our tissues to function properly. When we talk about hormones in this conversation, we're just really talking about three hormones: estradiol, which is a good form of estrogen, progesterone, and testosterone. When we have periods, our hormone levels fluctuate and change throughout the cycle. When we're pregnant, levels become very high in our body. But it's the changing hormone levels that often can trigger a myriad of symptoms. Ideally, in an ideal world, we want our hormones to be the right for us, where we're not experiencing symptoms and our body and tissues and organs are working as healthily as possible. And it's not just about how they are in menopause or perimenopause, it's when we're younger as well. So when people have hormonal changes that can dip before their periods, so PMS, PMDD, that can really trigger a lot of symptoms, but it's normalized. And this is one of my issues and bugbears, is that why should hormonal changes be normalized? Because they're not normal, because they're affecting people. And so often people think if we don't have our hormones, we wouldn't have any problems. So people block out hormones, but then you're not getting those cells working properly. As an example, my 22-year-old daughter uses natural hormones. She has migraine. She also has PMDD, so premenstrual dysphoric disorder. So a few days before her periods, she was feeling very low, very dark. It had been normalized by me as well for quite a few years. And then suddenly realizing actually this hormonal changes are triggering her migraines too. She can't have contraception because of her migraines, as in oral contraception. So she uses estrogen through the skin. She has testosterone and progesterone to rebalance her hormones. And she was saying to some of her friends recently at university, do you know what, guys? I feel the same every day of the month. I wouldn't know when my periods are. She has a coil as well. She said, I don't really wouldn't have a clue. Like, I feel the same. And they all said to her, how is that legal? How is that allowed? You are so lucky. And she said, Mummy, it makes me realize so many people are struggling with their hormones or changing hormones without being able to talk about it or without being able to receive any information or help or treatment. And I thought, she's 22, actually. It's hard enough being 22 anyway, but she needs to be feeling as well as possible. And if that means balancing her hormones, that's fine. but we put people into boxes in medicine. And if they haven't got a proper diagnosis, or they're not really severely affected or having terrible symptoms, then we can ignore it. And that's the same with a lot of women's health in general, really.
You mentioned estrogen. As I'm learning more and more about this over the years, estrogen seems to be one of the central hormones in women's health, like you mentioned, and it seems to touch everything, right? Brain, bones,
Mm.
skin, mood. Why is it that this hormone in particular is so central?
It's because we have receptors to all three hormones, estrogen, progesterone, and testosterone, in every single cell in our body. And we've just got a lot of information about estrogen, but we have about progesterone and testosterone. It's just been ignored for many years. But these hormones are made in our ovaries, of course, but they're also made in our adrenal glands, and they're made in our brain. So they are brain hormones as well. And that's what's been ignored for many years. I've got a pathology degree as well, so the study of disease. And I'm very interested in the way that our immune cells work, our macrophages. It's very geeky. But our macrophages are those sort of cells that will fight infection. They will gobble up any infection. They will produce cytokines, these chemicals that will kill any bugs and viruses, but they'll also help reduce inflammation in our body, so keep our body really healthy, repair any damage to our cells. So when we have estrogen, but also progesterone, testosterone stimulating the macrophages, they work better. If we don't have those hormones, they don't just not work as well, they actually can become pro-inflammatory and turn against us. So they can increase inflammation, and then they can produce different cytokines that will actually attack our body and increase inflammation in our body. And I think when you look at like a molecular basis how these hormones work, then it's quite easy to then think, right, so if we've got more inflammation in our body, that means we've got more risk of diseases as well, inflammatory diseases. And that's why menopausal women have an increased risk of heart disease, osteoporosis, diabetes, dementia, so forth. But the problem is people don't look at a cellular level. They're looking, oh, has she got hot flushes or not, without thinking what's going on in the body. And so the way that I think about hormones is quite different to others, because that's what I've always done in medicine, is go back to the basics, look in this cellular way, what's happening with the body.
Oh, that's so interesting. Isn't there also some like a connection here to autoimmune conditions?
Yeah, absolutely. We know that autoimmune diseases increase in women in their late 40s. Like, even my 14-year-old could tell you that probably might be related to hormones, because guess what? In the late 40s, hormone levels change. Most women are perimenopausal or menopausal. And we also know that progesterone also breaks down and forms cortisol and cortisone, which are the hormones of inflammation. So if we have less cortisol, or too much inflammation, that is going to increase our risk of inflammatory diseases and autoimmune diseases as well.
Wow, it's amazing how it feels like just now all these dots are being connected, especially
Mm,
with autoimmune health, because
mm,
2 in 3 autoimmune patients are women, and
yes.
endometriosis, for example, isn't that kind of now becoming more acknowledged that it's an
Yeah.
inflammatory immune response?
Endometriosis is very interesting because people traditionally are given contraception to block their hormones, because it's almost like the hormones are the baddies, but hormones are really good for us. They're really beneficial. So is blocking hormones the right thing to do? They give people synthetic hormones, which actually are quite inflammatory. They don't work the same way. They don't stimulate the macrophages in the same way, because they're chemically altered. And in our clinic, we often see women with endometriosis, and we give them the right dose of natural hormones, especially testosterone and progesterone, which are very anti-inflammatory, and find that they, not just their endo improves, but their other symptoms can really improve as well. It's such a shame there's not more research looking at the right things. There's a lot of research looking at the wrong things, or trying to find new medicines, new drugs, because the research is obviously funded by pharma. But sometimes in medicine, we've got to remember the basics as well.
Ah, super interesting. Okay, so then before we move forward, just to ground big three: estrogen, testosterone, progesterone. Could you
Mm.
just maybe summarize for each one of those, like what's the fundamental function or importance?
They're very similar chemically structured, but they all derive from progesterone. So progesterone gets broken down by enzymes to testosterone. Testosterone gets aromatase to estradiol, but they are different. So they do work differently in the body. Estradiol is, like I say, is very anti-inflammatory. When people have low estradiol, they often have symptoms of the vasomotor symptoms, the flushes, the sweats, maybe low mood, joint pains, palpitations, dry skin. Progesterone is very calming on the brain. Progesterone can help with sleep. It can help people feel more relaxed. It's very good at the way that the nerves in the brain work and function, so people's thought processes can be clearer as well. It can help even reduce headaches and migraines. A lot of people, they have low progesterone, feel quite anxious, they can't sleep very well, they can't think quite so clearly. And then testosterone, again, is the most biologically active hormone we actually have. We have more testosterone than estrogen when we're younger, and it works on every cell. But when people have low testosterone, they often have low mood, reduced energy, poor concentration. They might have reduced libido as well. They might have muscle and joint pains.
There's so many points in our lifetime when hormones can become super relevant, when there's the big changes that happen. I think with you, we really wanted to talk about menopause and perimenopause and really explain what's happening to the female body during those phases of life and some of the biggest shifts that are happening.
If you think of the word menopause, it actually means stopping periods. So pause is stop, men is menstrual cycle. Yeah. But what's really ridiculous actually is it has to be a year since our last period. That doesn't make sense actually, because in medicine you want to make the diagnosis the same day. So actually, what it really is that our hormone levels are low because our ovaries aren't working as well. And so the hormone levels reduce and then they stay low forever. So whether someone has symptoms or not, they still have low hormones. And that's really important because so many people think it's just a transition, it's just a phase that women grow out of almost, which we don't. But before our hormones stop being produced by the ovaries, they fluctuate and decline. So this fluctuation can cause very highs, very lows. They can really make a big difference. And so this change in the body can cause chaos, if you like, especially to the brain, but to the rest of the body as well. And the perimenopause can last 10 years or so before periods stop. A lot of people find their periods become lighter or heavier or closer together or further apart. And it's very hard to know what's going on because for many of us, these symptoms can be due to other things in life, of course. But like I say, the commonest symptoms are symptoms affecting our brains: low mood, poor energy, anxiety, irritability, poor sleep, fatigue, brain fog, reduced libido. But then people can have physical symptoms, so palpitations, urinary symptoms, vaginal dryness, soreness, muscle joint pains, dry itchy skin, sore mouth. The list goes on because they affect everywhere in the body. Not everyone has every symptom. Everyone thinks menopause is flushes and sweats. We did a survey recently of nearly 6,000 women and only 68% had flushes and sweats. So that means a third of women don't have flushes and sweats, which we see in the clinic all the time. But because so many of the symptoms affect our brain, a lot of people are being misdiagnosed as having depression and giving antidepressants. And the women say, I know I'm not depressed. And people aren't joining the dots and thinking about the myriad of other symptoms that can occur as well. But we need to also not be thinking just about symptoms. There's two reasons why I worry about women not having hormones. One is obviously they're suffering with symptoms. No one wants to suffer with symptoms. But secondly, people have risks to their future health, like I've already said, of these inflammatory conditions. And we know the longer a woman is without her hormones, the greater the risk of these diseases. And so once we realize that, then it's like looking at menopause in a different way, rather than few hot flushes, sweats, you'll just get through it because my mum did or my granny did or whatever. It's different because it's a hormone deficiency, lasts forever, and there are health risks with not treating. And that's important because we live so much longer as women.
Let's then dive into HRT finally. I'd love to really almost geek out on it because it really feels like the conversation is gaining more and more momentum. And I know you've been working in this for many years, but for me, it really feels like it's starting to really pick up in mainstream media as menopause became a bigger conversation. now it's maybe starting to become more nuanced, and HRT is becoming a bigger
Mm,
conversation, which is exciting. But can you maybe explain what is HRT? What does that stand for?
yeah.
How would you describe it?
Yeah, so HRT is only 3 letters. So hormone replacement therapy, but I don't actually like those 3 letters because it's not replacing. When we're giving it to people who are perimenopausal, we're just topping up what's missing. So we're not replacing hormones, we're just giving what's missing. And therapy sounds like you need a couch and it's like a talking treatment. So all it is a hormone treatment. If you had type 1 diabetes, insulin is a hormone treatment. But for this conversation, we're just talking about estradiol, progesterone, and testosterone. And so all we do is replace what's missing. And it's about getting the right dose to the right type of person at the right time. So when people are perimenopausal, their levels are fluctuating. They might need a small amount just to top up what's missing. And they might be more testosterone deficient than estradiol deficient. So they might need a relatively higher dose of testosterone compared to estradiol, or vice versa. We give hormones for 2 reasons: to improve symptoms, of course. Like, why should women suffer when they don't have to? It makes no sense. Like, no one gets a medal or a badge of honor for having symptoms. But more importantly, for me as a physician, is giving hormones will reduce inflammation, reduce the risk of diseases. When we think about health span versus lifespan, when we think about keeping people well for as long as possible, one of the things that we can do is replace the missing hormones to reduce the risk of heart disease, osteoporosis, diabetes, and so forth, reducing that inflammation in the body. And hormones can be taken forever because menopause lasts forever. And that's what we normally do. People have just been scared away from hormones for the wrong reasons. And globally, only 5% of menopausal women are taking hormones. So that means 95% of women will, most of them will be suffering with symptoms that are avoidable. But secondly, they will be exposing their bodies to an increased risk of diseases. And it's fine if they want to do that. You know, it's like saying women who never exercise have an increased risk of a heart attack. That is up to them. People who smoke 20 a day will more likely have lung cancer. It doesn't mean they'll get lung cancer, but it's not healthy. So we need to be thinking in a similar way with hormones. Like, why are so many women being refused a treatment that would improve their mental health, their physical health, their future health? It just doesn't make sense.
It's very interesting. So the message is really that hormone treatment has the potential of becoming the longevity tool for
Yeah.
women.
It's the most anti-aging treatment when you look at aging in the sense of longevity treatment that we have. And we need to be thinking about it because women are living longer. We know that the last 10 years of a woman's health is often or life is often in poor health. And it's more relevant than ever. 100 years ago, we
Mm.
didn't live as long as we do now, being menopausal. And so we need to be thinking about these diseases of old age and how we, as responsible people, can reduce the risk of those diseases. And often a combination of hormones and lifestyle make a massive transformational difference.
And how does it work? So let's say if I'm going through perimenopause and I'm having these sort of high and low fluctuations in my hormones, do you, and I were to come to you or to any other specialist that works in
Mm.
this, would I get my personalized quote unquote cocktail? That would, like, how does that work?
Yeah, so normally what we do is we often obviously assess people and make sure we think it's related to hormones, because there's lots of reasons why people can have symptoms. So as clinicians, we're not going to blame everything on hormonal changes. So we'll often do a blood test looking for other reasons as well. And then we'll start a certain dose or type of hormone and then review people very closely. I often do blood tests once they're on treatment to see whether they're absorbing the estrogen, the estradiol, whether they're needing the testosterone and absorbing it, whether the dose needs changing. And then we look at blood tests, but more importantly, look at the patients and look at the symptoms and see how they're improving. Any improvement can take a few months because it can take a while for the cells to actually change the way that they function and process. But often with the right perseverance, the right experience, people can really make a huge difference to their symptoms and their future health. There was a study from 2002, the WHI Women's Health Initiative study. It was a randomized controlled study, and it was the biggest travesty to women's health ever. It was such a shame for many reasons. Firstly, it was giving the wrong type of hormones to the wrong type of women. So they were giving synthetic hormones. They were giving the estrogen that was made from pregnant horses' urine and a synthetic progesterone called progesterone acetate. They wanted to give it to women without symptoms to see if it would help future health. So it's quite hard to find women who don't have symptoms. So they gave it on average to women in their 60s. A lot of these women had heart attacks and strokes and were overweight. So they weren't ideal candidates, really. And a lot of them were more than 10 years since their menopause started. And then the study had been going for a little while, and then they decided to stop it because they thought that there was an increased incidence of breast cancer. They didn't analyze the data properly, and they just went straight to the media and to the medical press. And that was the big mistake, because when you do a study that size, you have to analyze the data really carefully, and they hadn't. When they analyzed the data properly, they showed two really interesting things, or they showed lots of things, but two really important facts. One of them was that women who only had estrogen, so they didn't have the synthetic progesterone, had a 22% lower incidence of breast cancer. But that never made the front pages. It was all about risk of breast cancer. The other thing that they showed was that this risk of breast cancer was with the people who took the estrogen with the synthetic progesterone, progesterone acetate, but this risk was not statistically significant. So it could have just been a chance thing anyway. But because of that study, millions of women globally have missed out from having a treatment that will help them feel better and improve their future health. But the problem is there are people that keep going on about this study. The warnings that were with HRT, so when I prescribe it as a doctor, it comes up with warning on my clinical system. As a patient, when I take my HRT, it will say in the insert, even the vaginal hormones that I use will say risk of clot, risk of heart attack, and so it's scaring doctors and women to this day. And I don't quite understand why, because we know it's so helpful and useful and beneficial. But one of the problems is, since HRT prescribing's halved in the UK, there's lots of other drugs that have come to market. So drugs that help osteoporosis, drugs that help blood pressure, drugs that help depression. And so women are being medicalized with the wrong, inappropriate treatment that's not treating the underlying cause, which is probably good for the pharmaceutical companies, but it's not good for the individual woman. And it doesn't make sense as a doctor, because as a doctor, you want to treat the underlying cause.
In preparation for this interview, I've asked some friends, what do I ask Dr. Newson? Because quite a lot of people I know in my network are very aware of you. I've even had people that were like, oh my God, I've actually been to the clinic. She's completely changed my life. I've had such incredible feedback. And yet there is this story or narrative that it's not quote unquote natural.
I think that's very interesting, actually, because a lot of people think it's not natural, it's natural to be menopausal. So there's a few things that I can counterattack that, if you like, not attack, but just say, because it's a debate, isn't it? One of the things is evolutionary, we are designed as women to reproduce and then die, because that's what we used to do in the Victorian times. So it's not natural to live decades without our hormones. We don't become pregnant as much as we did. In the Victorian times, our average age of menopause was about 57 and average age of death was 59. We don't have a menopause at that age. It's usually younger and we live for a lot longer. But the other thing is, we do lots of things in medicine that you could argue is play with nature. So being in pain in childbirth is natural, but it's not very nice to be in pain. One of the things that I often compare it with is raised blood pressure, hypertension. A lot of people with hypertension don't have symptoms. We treat it and lower blood pressure to reduce risk of a heart attack and stroke, which is very important. I think most people would agree that's fine to play with nature, because hypertension increases as we age. But if we give HRT to women who are menopausal, their risk of a heart attack halves. It's less than if I gave a blood pressure lowering drug. So even if I was only giving HRT to reduce risk of blood pressure, why am I not allowed to do that when I can give a blood pressure lowering drug? But actually, I can't think of a blood pressure lowering drug that will also strengthen bones. And osteoporosis affects 1 in 2 menopausal women. So again, why should 1 in 2 women not be able to get strength from their bones from a very safe natural hormone? But again, it's about choice. I think this is the thing. Lots of people think we don't have to do anything. Like, I have chosen, I don't drink alcohol. It's fine. There are risks of drinking alcohol. There probably are some benefits as well, but I wake up in the morning quite happy that I don't drink alcohol. I do a lot of yoga. I really like doing headstands most morning. I don't expect the whole world to do headstands just because I do it and enjoy it. But what saddens me is that there are women globally who want to have hormones and they can't have them, and they're being given drugs such as antidepressants, which have far more risks than HRT. So it's just looking at the bigger picture, really, I think is really important. And also looking at what are the risks of not having hormones. So for me as a menopausal woman, if I didn't take hormones, I would not be working because my brain does not function. I would not be happily married because I was just an argumentative, horrible, irritable person. I wouldn't be like as close to my children. But I also would have this increased risk of osteoporosis and heart disease and so forth. And my big fear is osteoporosis, actually. So as a woman, I do weight bearing exercises. I eat calcium in my diet. And it's just a choice. But actually, the choice isn't there for many people. So yeah, you could say it's playing with nature, but everything we do is playing with nature, really, in some ways.
I love that answer. And ultimately, it's about choice. I think that's the central argument that you make. And it's so interesting that it comes up again and again in women's health across the board. For some reason, we have to surface it again and be like, we're not forcing anybody to do anything. No. It's just choice.
And do you know what? Viagra is available over the counter. Like, no one questions men whether they buy it or not. You don't have to justify it. It's because it's women, and it's very good for society for women to be invisible as they age. And sadly, they're less invisible if they're taking hormones.
If you could commission any study and you had no limitations in terms of like funding or sample size or whatever it would be, what would you want to find out, or what kind of hypothesis would you like to test?
Oh, wouldn't that be amazing?
Right.
That's never going to happen though, is it? I'm like a kid in a sweets shop. There's loads you can do. I would really like to focus on individualization of doses and looking at inflammatory markers and future health. We don't need to do any more studies about the risks or perceived risks of hormones. We want to look about the benefit. I want to look about how I'm really interested in inflammation that occurs as we age. So I want to look at markers that will reduce and how they change and optimize. And I want to look at the biological effects of those hormones in my brain. I'd love to have looked at my brain scan before and after, my brain activity scan before and after hormones. I'd like to do a lot more with the brain, because without a brain, we're nothing, really. And I'd like then people to think about menopause as a brain problem, not an ovarian problem, because research will reframe how we think about things.
And when you say inflammation, what do you mean? Everywhere in the body? Like, how do you define that?
Yeah. So inflammation, if you think in a very simplistic way, if you cut your finger and it gets a little bit infected, it becomes a bit swollen and a bit sore and a bit tender. And that's because all your cells are working there to try and repair the tissue. So any damaged tissue, there's this increase, like cell turnover, increase damage to the tissues with inflammation. And if you keep having this inflammation going on, you get genetic changes as well, and the cells start to change and shift, which will then, they won't repair each other themselves as well. So that's why they become diseased. The organs can become diseased, or the cancer can form. And it's very important that our cells work as well as possible. And any damaged cells are got rid of by our body as much as possible as well. And so if we don't have those fine-tuning sort of processes going on, we have more of the bad cells that aren't mopped up, less of the good cells, increase damage, increase this sort of inflammation that's going on throughout the body. And that's why people get this increased atherosclerosis, this furring of the lining of the arteries, increased risk of a heart disease, the brain not working properly, because we need to keep any of this inflammation down as much as possible. And that's when you look at how our cells work. And even some of you might have heard of mitochondria, the powerhouse of our cells. They produce the energy that we need. Unsurprisingly, we've got receptors for estrogen, progesterone, testosterone on the mitochondria. So if we have the mitochondria working better, we've got more energy for all these cell processes to occur. So our cells function really well. which will then reduce inflammation, keep us really healthy. And we have to have a different way of thinking about preventing disease. So often in healthcare systems, we're treating diseases that happen. And we know that like inflammatory diets, processed food will increase inflammation. We know smoking, drinking, not exercising increases inflammation. But for men and for women, not having hormones, so men not having testosterone, women not having estrogen, progesterone, testosterone, will increase inflammation far more than poor lifestyle. But it's just been ignored for so long. But it's just looking at those processes, they're the same throughout the body.
Fascinating. I hope people are gathering from this conversation, at least this is the inspiration I'm getting, is that this could potentially be a very central technology to female longevity and aging.
Absolutely. Yeah,
right?
It's really important. And I think people are waking up to longevity, but not in the way of hormones. And it's really interesting. And I think partly it's because hormones are very cheap. They've been around for many years. You don't need to invent something new and different because it's just there. But actually, when you're talking about population health, and I'm very interested in helping everybody, not just wealthy people. I'm very worried about the diseases of deprivation, and there are a lot more inflammatory diseases in people with low socioeconomic classes. I would much prefer to do something that's probably a bit more crude, helping more people, than doing so much micro hacking that it's only helping a small number of people.
I'm sure you've seen on social media in the last, I think, 5 years, maybe since COVID, there's more and more influencers, there's more products, and especially on hormones, this concept of hormone balancing is out there. What is your sort of general take on it? And what would be your recommendation to women, to somebody that's on social media? How do you distill noise from science?
It's really hard. There's 1.34 billion menopausal women, and I've already said only 5% receive evidence-based treatment. So if I was a marketeer wanting to make a lot of money, I would look at those 95% of women and think, come on, these women are suffering, let's try and sell them. And that's what happens a lot. And quite often I get asked if I could be a face or name behind a new menopause shampoo or face cream. And it's no, actually not. Menopause is a multi-system disorder. It's not just affecting our face. It's not just affecting our hair. It's just crazy what's going on out there. So I think the most important thing is look at the evidence, look at the credibility of the person. And I'm very careful what I put on social media. I'm very aware of being a doctor and making sure I have good medical practice. I know about social media rules and conducts and behaviors as a doctor. And that is so important because it's such an easy place to think you're doing a good job or to know you're doing a bad job, and you give this information that you would never tell your patients or you would never tell your best friend. Somehow it's acceptable on social media. So we have to be really careful what's going on out there.
If you were to redesign the entire system, how would you embed menopause into both healthcare and culture?
Firstly, wouldn't call it menopause.
Okay.
I would call it what it is, and I would have 3 separate terms. So I would have estrogen deficiency, testosterone deficiency, progesterone deficiency, because you don't lump thyroxine and insulin together. They're 2 separate hormones with 2 separate conditions. So I would talk about it what it is, actually. So I would get rid of the word because it's not all related to periods. And I would enable people to have information really early on. I would really educate everybody, every healthcare professional that sees women. So that's all healthcare professionals. So we can pick it up a lot earlier. My sadness is that I see so many women who've been struggling for years and not being able to receive the right treatment. And when they have had treatment, they say, I wish I'd started that before. I wish I'd had it. And even personally, I wish I'd started testosterone 10 years before I did. But you don't know what you're missing until you have it back. But we're letting down women by ignoring them and not being more proactive in helping diagnose and treat them properly.
Love that. Okay, we scrap menopause from vocabulary, and you would call it what it is, which is hormone deficiency, and make it more specific in terms of what exactly it is, so you can actually treat it better. Interesting. That's quite a reframing of the entire industry in many ways.
Totally. Wouldn't that be good?
Last question, a bit of a philosophical one. So just if we zoom out of everything that was specific that we talked about. How has like studying hormones, what has it taught you about life, nature, universe?
It's taught me to be more curious, actually. I wish I'd known what I knew now 30 years ago when I qualified as a doctor, or 35 years ago. I wish like someone had really taught me the obvious things. So I feel like quite cheated as a doctor, and I feel quite sad that I've missed out so much for my patients by not having the information and knowledge. And I think this like professional curiosity has to be ignited in other people as well. The more I learn, the more I want to learn. The more I see, the more I can't unsee. Once you see women suffering, you can't unsee it. And that's the biggest tragedy, actually.
Thank you. Thank you for your time. Thank you for everything that you're doing.
Thank you.
Really, really grateful. I've learned so much. Hopefully, the curiosity has been sparked in people
I
that
hope
are
so
listening
too.
to this. Yeah, and thank you for all your work. If I can ever be helpful in any way, let me know.
Oh, thank you. And thanks for inviting me.